Start the recording.
So, start?
Yes.
Yeah. Welcome. I am Dr. Sanjay Kulkarni from Urology Institute. With me is, I welcome Dr. Christina she is a scholar from British Association of Urological Surgeons. She will be with us at Europol for 1 month. And we have our first year resident, Dr. Manisha. So we are going to discuss about the differences between the surgical training or urology training between India and England. Okay, my question, I'm going to have lots of questions to you. First of all, you are in the 5th year of your residency?
So, yes and no. So the way it works in the UK is you do 2 years of foundation training and then 2 years of core surgical training, and then after that you do 4 years of specialty training. So I'm ST7, that means I'm in the 7th year of my urology residency training, but then the 9th year of residency overall. It's quite a long process in the UK.
So after your basic medical graduation, it takes about 7 years for you to become a trained urologist?
7 to 9 years, because you don't go straight into urology when you finish your basic.
7 to 9. In India, Manisha has done 3 years of general surgery. She has done appendectomy, you understand, all gallbladder surgery, and now she's going to do 3 years of urology. So this is a different perspective. How much general surgery have you performed?
So I did my core surgical training. Overall, I did about 1 year of general surgery.
1 year.
1 year general surgery.
So 3 years of general surgery is a little better. So I'm just asking you.
I guess it's difficult to know because you spend 3 years just doing general surgery, whereas in my core surgical training I did 1 year of general surgery. In my foundation training I also had another year of general surgery, but that wasn't really operating, that was more based on the wards, so much more ward work.
So after you finish your residency program, you want to do fellowship?
Yes.
How easy it is to get a fellowship?
So it depends on what you want to do. Obviously the oncology robotic fellowships are the most popular, but I have a pretty good chance of getting into a fellowship in the UK.
And the fellowship is for 1 year?
1 year.
Or 2 years?
1 year.
1 year. 1 year. And after that you become eligible. You are eligible to become consultant now.
Yes, from August I'm eligible.
Eligible, but you want to do fellowship and then join the Bristol.
Yes, I'd like to do some subspecialty training, which the residency won't be doing.
So suppose there are 10 urologists. How many of them go for fellowship and how many go into what you can say as a general urologist in the society?
Probably about 50-50.
50-50.
Yeah, I would say. If you look at my cohort, probably about 50% go on to a fellowship and 50% would just do core urology or lots of procedures.
Now with the recent advances in urology, we are doing less and less of what you can say open surgery. So in your residency, have you seen a loin incision for kidney surgery?
No. I think there's a very little open surgery. At the moment in the UK, there's a big fear that trainees won't be able to manage emergencies, so open ureterectomy implantation, bladder repair, trauma nephrectomy, because we just don't get any exposure to it.
Next question is, there is a patient who has a congenital pelvic junction obstruction. Do you think there is a patient in UK who is undergoing open pyeloplasty?
No, very unlikely.
Very unlikely. So what's the chance of the patient getting laparoscopy versus robotic?
I think it depends on which region you're in, but the move is definitely towards robotic pyeloplasty. There are still some people doing laparoscopic, but the new trainees coming through would be learning robotic.
Suppose I have a 2 centimeter mid-uretic stone and offer that to a British urologist to make a loin incision, an incision where it's a mid-ureter. He should make an incision, extraperitoneal dissection and do ureterolethotomy, and the stone should be in the center of the incision. Is it possible? Common, uncommon?
I have never seen it.
You have never seen it. What about open prostatectomy for benign disease? Like suppose you have, yesterday we had a patient with 465 gram prostate who was bleeding. So suppose nobody will be able to do that endoscopically, maybe robotically, but open surgery, open prostatectomy.
So in the UK, they get a HOLEP or they get a robotic Millens.
Robotic Millens. Manisha, you want to ask them some questions? Ask Christina.
But even in your general surgery, you training, so no uro cases get operated in general surgery.
No, it's very separate.
Okay.
They're very separate specialties.
So in that also you don't get any exposure to open cases.
In general surgery, yes, there was much more exposure. When I did my general surgery, there was much more exposure to open cases. At the time, this was quite a few years ago now, there was less robotics, so it was mainly open, I did a lot of open or laparoscopic surgery.
So after you finish your residency in Bristol, you will move to London
To do a fellowship, I did, yes.
for 1 year, and then there is a high chance that you will get a job in Bristol again.
Yes.
So Bristol is a famous place for urology. How many urologists are there in one group of NHS hospitals?
So in the hospital is Southmead Hospital, it's part of the Bristol Urological Institute. There's about 20 urologists.
20. I don't think in India we have 20 urologists in any single center. Huh? I'm curious. So out of 20, everybody does everything?
No, so
No.
it's all very subspecialised.
Mhm.
So you know, you're very much in your subspecialist interest. So you do genital reconstruction and andrology, or you do upper tract oncology, or you do pelvic oncology. There's a few people doing core endourology. There is a little bit of a mix, so everyone might do a TURP or a circumcision, but not generally.
But out of 20, you may be on call maybe once in 3 weeks. So in the evening, if there is a patient with ureteric colic and he has fever, you may have to do degestanting as an emergency.
Yes.
Or maybe clot retention, you will have to evacuate, even if you are a specialist.
Yes.
Yeah.
Well, I mean, ideally you'd have a resident that would do it and you would supervise them, but yes.
And in England, you work 5 days, Saturday, Sunday off.
Yes,
Saturday off.
unless you choose to do extra.
Extra, okay. And there are 2 sessions per day, so in a week there are 10 sessions. So normally people work for 10 sessions in NHS or few sessions in NHS and few sessions in private.
So most consultants would be on a 10 session PA, but they would probably try and condense that to maybe 3 or 4 days if they want to do private. So we do 3 session operating theatres on Sundays. That would give you an extra day to do private during the week if you do 3 sessions.
So suppose there is a urologist who is in 8 sessions in NHS and 2 sessions in private, and then out of 5 days he operates every day, does surgery every day.
No.
Then
Most in the NHS, most surgeons are doing 1 to 2 days
a week.
total a week.
And it's a half a session or a full day session?
So either. So for example,
Your session starts at what time in the morning?
so probably start about 7:30 and ends around 1 midday-ish.
And suppose your list starts at 7:30 and the surgeon appears at 8:30, what will happen?
So to be fair, the surgeon's getting at 7:30. The operating probably doesn't start by the time everyone's seen the
No,
patient.
so suppose this and the nurses reported to the higher authority that the surgeon came late.
That would be a problem. And 8:30 is a bit late to turn up for work in the UK.
Okay. Any question? Anything that you ask about Indian urology? So in this hospital, if I see a patient at 8 o'clock, I ask him, have you come for consultation or for surgery? If he says for surgery, he's a young man, looks fit, I say don't eat or drink anything and we can do surgery at 1 o'clock, maybe next day morning. If he is on blood thinners like clopidogrel, then I need a 2D echo and he may have to wait for maybe 5 days to stop medication. So our job is to offer surgery. Next question is, in India we have a choice. A patient has a choice. There are 115, 120 urologists in Pune. So on a particular road, there could be 10 urologists. And the consultation fee could be maybe around 10 pounds. So he could see number of urologists in one day and choose whatever he wants. And he has a choice of the surgeon. In NHS, there is a choice of a surgeon?
There's an illusion of choice.
Illusion.
But essentially, no, you'd get referred to your local centre if they offered whatever you wanted. If you want something more specialist, you then get referred on. Most teams operate on a pooled operating list, so someone might see the patient in clinic, but they don't necessarily operate on them because everyone in that subspecialty department shares the same waiting list.
Oh. So there is a chance that you may be operating on a patient whom we have not seen before.
No, received by one of my colleagues, yes.
Mm-hmm. In India, we can have a patient seen without being referred by a doctor or a urologist, doctor or a, what you call general practitioner or a physician. He can take an appointment of a urologist. That's not possible in England.
No, so patients are referred electively by GP or emergency via A&E and GP.
So a referral letter is important. So suppose I have ureteric colic, I can go to the emergency and get seen?
Yes, so if you came in with suspected colic, you'd be seen by the emergency department and they'd get a CT scan, and once you had a proven stone, then you'd be seen by a urologist.
Okay. So life is comfortable and easy in England?
Depends on what you call good.
No, my next question is, what is the chance of you, a patient, if you do surgery on 10 patients, one patient may be unhappy around the world for some reason because the outcome may not be as expected, and then what's the chance of getting sued in England?
Not that high, pretty low. I'd say pretty low. I mean, I can probably count on one hand the number of urologists I know who might have been sued. They do complain, and they can go through a hospital complaint system and they might get some compensation from the hospital, but actually being sued and having to go to court, relatively rare.
So he complains to the hospital authority, there is a committee, and then suppose the committee thinks that patient is right, he will get money from the hospital.
Yeah, they could.
He could. And suppose he is not happy, then he can go to the court of law.
Yes, but they like to avoid that as much as possible.
Okay. Anything else you want to say?
Not sure.
No, you have been in Europol now, today is? Huh? Okay, you have been here for 3 days. Are you happy to see some good surgery?
Yeah, no, I'm really happy. The volume is amazing. We do not have this volume of operating, in the UK, and I think the model is very different. So in the UK, it would be one consultant with one trainee in an operating theatre, rather than lots of different operating theatres and the consultant goes around that. Doesn't really happen in the UK.
And do you like this camera system?
Oh, it's so good being able to see what's going on.
Even if you are watching the urethroplasty from the surgeon's right shoulder, it is better seen on the TV screen. You agree with me? So this is a beautiful teaching tool, and we have been using it for the last 15-20 years. But I don't know, there is no duplication of the system anywhere in the world. We are very happy, but nobody is copying us.
I think it's very good for teaching and education. They do it a lot in robotics now because it's very easy to record the console.
Yeah.
I think they should probably think about doing it in other questions.
My question is, do you think when the new generation urology training will come out, robotic surgery is a specialty or everybody is trained in robotic surgery?
It's difficult to say. I think in the UK at least, I think it will probably be a subspecialty still.
So during residency you are seeing enough of robotic surgery. But if you want to practice as a robotic urologist, then you need a fellowship.
I think so. It depends on where you are, but I think most people who want to do robotic surgery now are getting the fellowship. Very, very few people.
I heard that suppose you are trained, suppose we talk about stress incontinence. If you have been trained in TVT from above down, you are not allowed to do a transobturator sling. Is it?
We're not allowed to do any slings.
Huh?
We're not allowed to do any slings.
You?
There's a total pause on mesh in the UK.
Also, mesh is not used at all.
Not at all currently. In the
So
UK.
all patients get a facial sling.
Probably a fascial sling.
So open surgery.
Yes. I think there's a couple of people doing it robotic in London, maybe one or two, but yes.
So this is very important. No TVT, no TOT in England.
No.
So there is this difference. No? So the commonest operations performed must be TURP or laser prostatectomy.
TURP still.
TURP, bipolar.
bipolar TRP.
Yeah. And which system is popular there? Olympus or
Olympus.
Olympus.
Yes.
Olympus is best.
Yes.
Yeah.
Very much so.
And then apart from TRP, rigid ureteroscopy
Yes.
and RIRS, retrograde internal surgery, and the thulium fiber laser is popular there.
No, still holmium.
It's homeopathy.
Yeah, thulium is coming in more, but still holmium predominant.
We have a thulium laser for last 5 years here. And what about PCNL? When I was there in England, John Wickham started doing PCNL in 1981 in England and Germany simultaneously. So that was what you can say birthplace of PCNL, England and Germany put together. So what about the incidence of PCNL? Still high or going down?
Still high, but most urologists don't do their own tracks. That's done by an interventional radiologist, and then the urologist will put the scope in and do the procedure.
Is there something, who does the flexible cystoscopy now?
Lots of nurses.
Oh, this is very interesting. And can so when my grandchildren in America visit a doctor, they are seen by, for cough and cold, they are seen by a nurse practitioner, and she can prescribe medication. Can she prescribe medication in England?
Yes.
So I'm teasing my urology colleagues in India. Nurses are allowed to do flexicystoscopy and allowed to prescribe medication. What is left to you?
And prostate biopsies. There's some do prostate biopsies as well.
Prostate biopsy also? Yeah.
So a lot of nurses do both in urology, cystoscopy, prostate biopsy, urodynamics.
Urodynamics.
A lot of that's done by nurses now.
Anything else you want to say? What's your experience of coming to India?
Oh, I think it's great. I mean, India, I really like. It's the second time I've been here. I really like India. It's very busy and very good food.
Yeah.
Everyone's
People
very,
are nice.
Yeah, everyone's very welcoming.
And compared to whatever was in your mind coming to India, is it the same or is it better?
Actually, probably a bit better.
Yeah. No, because many places around the world they say there are snake charmers and there are elephants on the road. This is a description of India. Not true, no?
No.
And most important, Pune at least is a very safe place.
Yes.
My wife can go on the road 12 o'clock midnight alone. We are not worried.
No.
So is it possible in all parts of England?
No.
Huh?
No, not all parts.
No. So Pune is a very safe place.
No, it's
Pune is
really
a very
lovely.
safe place. Welcome and thanks for sharing your views on what differences between the training and practice patterns of India and UK. Thank you very much, Christina.
Thank you.
Thank you.